So the topic given to me is low-grade lymphoma treatment approaches. So I'm going to talk about low-grade lymphoma in the first few slides, and I will point out the treatment options and how it has changed over the past several years. As Dr. Stiff said, there has been dramatic changes in the way we diagnose and treat this group of diseases, and most of it happened in the last 10 or 15 years, and I will point out to some of those changes. So this is a large database that is used by oncologists as well as researchers to find out the number of different types of cases, the SEER database. So if you look at the common types of cancers, breast cancer is number 1, but non-Hodgkin's lymphoma ranks 7. About 71,850 new patients are expected to be diagnosed in 2015 based on the statistics, although it forms only about 4.3% of all the cancers, like you see here. So it is certainly a fairly common disease. I think that's the point of the slide. And if you look at the distribution based on age, most of the cases are during the age group that is pointed out here, that is 65 to 74, that's a peak. And this is important in treatment. As you can see there is a group of younger patients who also develop the disease, even though numbers are smaller. But younger patients, as you know, can tolerate treatments better. So we try to point out or try to offer them more intensive treatment, which has a chance of longer duration of remission to patients who can tolerate the treatment. On the other hand, when it comes to the older patients, we have to look at quality of life as well as disease control without causing significant morbidity or side effects from the treatment. And because of many other diseases they may have in terms of diabetes, high blood pressure, kidney function, they may not be able to tolerate intense treatment. So these are all factors that will determine what is the most appropriate treatment for a patient with low-grade lymphoma. So if you look at the different types of non-Hodgkin lymphoma, the commonest non-Hodgkin's lymphoma is still diffuse large B-cell lymphoma, which is an aggressive lymphoma, not a low-grade. Under the low-grade, follicular lymphoma is the commonest. And as you can see here, there are smaller number of other low-grade lymphomas, like, for example, some of the mantle cell lymphomas, small number of them can behave like low-grade lymphoma. You have marginal zone lymphoma, which I will talk about in the next slide. Lymphoplasmacytic lymphoma, those are also low-grade B-cell lymphomas. It's important to know the type because not only in terms of diagnosis, but also in terms of treatment, you may be making major differences in treatment decisions based on the exact subtype of the lymphoma. So this slide gives you a list of the common types of low-grade lymphoma, which I just talked about. Follicular lymphoma is the commonest. The second one is small lymphocytic lymphoma, which is a disease similar to chronic lymphocytic leukemia. In fact, under the microscope, it may look like very similar morphologically as well as based on the protein expression and all. It's the same in chronic lymphocytic leukemia, except in CLL or chronic lymphocytic leukemia, the number of lymphocytes with those features in the blood is higher. You have a group of marginal zone lymphoma, especially the so-called splenic marginal zone lymphoma, which is a little different from the other types of low-grade lymphoma, where patients usually come with a big spleen, low blood counts, not much of lymph node enlargement, which, as you know, is typical of lymphoma. And these patients can get long remissions by just removing the spleen. As you know, surgery or taking out the area of tumor is not a typical treatment for lymphoma, whereas in this lymphoma, you can take out the spleen and you can get very long remissions. The other one I want to point out is the mucosa-associated lymphoid tissue lymphoma, which is also called MALT lymphoma. It's a low-grade lymphoma, typically involves the stomach. What I want to point out, it is a typical lymphoma that is associated with a infectious agent. So it is associated with H. pylori or Helicobacter pylori, which is a bacteria present in the stomach. And some of these patients can have long-term remissions with a course of antibiotics which is directed at the bacteria without chemotherapy or radiation. Here is a leukemia, is another form of low-grade lymphoma. Also, Waldenström's, some of you may be interested in that. Waldenström's is interesting because it is a low-grade lymphoma where the lymphoma cells make an abnormal protein, and this protein builds up in the blood. And as you know, if there is excess protein in the blood becomes thick, and it can lead on to blood clotting, bleeding, those kind of disorders. So that is particular with the Waldenström's, and the treatment is usually directed towards that. If you have high proteins in the blood because of this lymphoma, we may sometimes even have to remove the protein with a machine. We call it pheresis in order to reduce the risk of clotting, in addition to treatment of the lymphoma. So this slide summarizes some of the things which I just mentioned. So the low-grade lymphoma forms about 30 to 40% of all the lymphoma cases. And most low-grade lymphoma patients are asymptomatic without symptoms for a long time. And that's the reason why in many patients the diagnosis is delayed. Many times it is diagnosed by a routine physical examination. The person goes to the primary care physician for a routine physical examination, and the physician feels a lymph node, enlarged lymph node, may wait for some time or give a course of antibiotic. It doesn't go away, then decide to biopsy it and established low-grade lymphoma. And then you are referred to an oncologist who does some other tests, which I will talk about, and then at the end tells you that you have low-grade lymphoma, you don't have any need for treatment, we will continue to watch you. This is kind of a usual scenario with the low-grade lymphoma. So because of this, majority of patients with the low-grade lymphoma, by the time they come to the doctor, they have an advanced stage of disease. In other words, stage 3 or stage 4, because the disease doesn't cause symptoms for a long time. And these statements, as you can see, this is an older slide. I wanted to mention the changes. You just heard from Dr. Stiff, the median survival is much longer in low-grade lymphoma nowadays because of the advances in terms of diagnosis as well as treatment. And we believe that some of the patients with low-grade lymphoma are getting cured, even though if you do the textbooks, it may say it is an incurable disease, but some of the patients with new treatment options, they are having long-term remissions, which is almost like cure. And one thing to remember is some of the patients with low-grade lymphoma can have transformation to an aggressive lymphoma. And that's one of the reasons why patients under observation should be closely monitored. This is the appearance of the commonest low-grade lymphoma under the microscope. This is a so-called follicular pattern that gives the name, and these are the appearance of the cells under the microscope. If you have a follicular lymphoma, it is important to know what is the grade. We usually talk about grades 1 to 3. Grade 1 and 2 are treated just like a low-grade lymphoma, which I'll talk about how. When it comes to grade 3, particularly grade 3B, most of us would treat these patients like an aggressive lymphoma because biologically these patients behave just like an aggressive B-cell lymphoma. So it is important to know the grade, and that is why when you're diagnosed with a low-grade lymphoma, it's always wise to have a second opinion, and the biopsy slides to be reviewed by a pathologist who specializes in lymphoma would be something very important in terms of deciding what is the best approach. How do we diagnose lymphoma? Patients typically come with B symptoms, but not all patients do come with B symptoms. As I said, in low-grade lymphoma, many patients don't have symptoms. But if they have the typical B symptoms you may have heard about, that is fever, night sweats, and weight loss, that's classical. But patients may come with other symptoms, depending on where the lymph node swelling is. For example, if you have an enlarged lymph node pressing on your breathing tube, they may have breathing difficulty. Or if it is in the stomach, they may have symptoms of intestinal obstruction. So it can be based on the location of the tumor also. Then you do a physical examination, which we may be able to find enlarged lymph node or enlarged spleen, and those are common findings in patients with lymphoma. And then you do some laboratory studies. For example, a blood count, complete blood count. If all the blood counts are low in a patient with lymphoma, we may be worried about lymphoma affecting the bone marrow, because as you know, bone marrow is the place where all the blood cells are made, and blood count may go down if there is a lot of lymphoma in the marrow, and that may be an indication for treatment even if the patient doesn't have any symptoms. Biopsy of the lymph node is probably the most, lymph node or the tumor mass is the most important test. And you may have heard about needle biopsy and open biopsy. Many a time, needle biopsy is attempted because it is easy to do in the physician's office. But in lymphoma, we like an open biopsy. In other words, we need a piece of the tissue, if possible, a whole lymph node, because we have to do a lot of different studies, staining it with different chemicals, looking for different proteins on the surface of it, as well as chromosomes, genetic pattern, mutations. But these are all going to determine not only the prognosis, but also the treatment options, as I will show you later on, because nowadays treatment is based on many of these factors, not just the name of the subtype of lymphoma. So always make sure that you have a proper biopsy and a very clear diagnosis in terms of the subtype and the other features I mentioned. Bone marrow biopsy may be what will give a diagnosis in some cases where the lymphoma is only or predominantly in the bone marrow. And bone marrow biopsy is also done in most lymphoma patients because it is part of the staging workup to find out the stage of lymphoma. Scans should always be part of the staging. CAT scans can give us the measurement, the size of the tumor, location of the tumor, and PET scans, as you know, can tell us about the function of the tumor. In PET scan, you inject glucose that is radio-labeled. Depending on how much glucose is taken up, the tumors will light up, and based on the intensity of lighting, we can say it is a low grade or is there an area that has a transformed aggressive lymphoma. So these scans are all important in the workup of lymphoma. Let's focus on treatment. Now, I'll focus on some of the principles of treatment because one of the major part of the treatment in lymphoma is targeted treatment, which the next speaker is going to address in detail. But I will focus on the treatment principles here. So, if you have a patient who has a diagnosis of low-grade lymphoma and the staging workup is completed based on what I just showed you, then you can classify that patient into either a localized disease or an advanced disease. Localized is the term you use for a patient who has a stage 1 or stage 2 lymphoma, and advanced would be stage 3 or stage 4. A localized low-grade lymphoma can be treated with radiation just to that, if the area that is affected. And so local radiotherapy is an appropriate treatment for a patient with a localized low-grade lymphoma. It can bring in long-term remissions. Now, the patient has advanced disease. You group them into low tumor burden or high tumor burden. And this is based on certain criteria we use. And the criteria involves, for example, the size of the tumor or the mass, the number of lymph nodes, certain markers in the blood like LDH, the blood counts. Those are all factors we put in to make that decision whether the patient has low tumor burden or high tumor burden. In patients who have low tumor burden and no symptoms, observation or wait and watch is very appropriate. Whereas in patients with high tumor burden, most of the time therapy is indicated. Treatment is also indicated if the patient has symptoms, or the symptoms which I mentioned before, or if lymphoma is causing organ dysfunction, like bone marrow dysfunction. I told you that if the blood counts are low because there is a significant amount of lymphoma in the marrow, that's an indication for treatment, even if the patient doesn't have any symptoms. So those are all factors which will determine need for treatment in a patient with a low-grade lymphoma. And there are many options. We talk about watch and wait, which even in the modern era, where there are a lot of different treatment options which can be delivered to the patient with much less side effects, but still watch and wait is appropriate in a subset of patients. Some patients may consider it as watch and worry because you have a diagnosis of lymphoma and nothing is being done. But if you look at the data, watch and wait in such patients is very appropriate because treatment doesn't make much of a difference in the long-term outcome in those patients if there is no indication for treatment. Radiotherapy, I already mentioned, the primary role is in localized lymphomas where you can get long-term remission or even cure. Although there is subsequent data showing that patients who are not radiated can also have a similar outcome. So this is an option for localized lymphoma patients. Chemotherapy has been the main cornerstone of treatment. In low-grade lymphoma, the conventional chemotherapy options we have used in the past include regimens or combinations of chemotherapy drug like CVP, cyclophosphamide, which was mentioned before, vincristine, prednisone, and the other option is a group of drugs we call as purine analogs, which is a classic example is fludarabine, which is less and less commonly used nowadays because we have another drug similar, which is bendamustine or Trianda. A combination of bendamustine with rituximab is a very appropriate first-line treatment for patients with low-grade lymphoma who needs treatment. So chemotherapy is effective, even though we are using less and less, but chemotherapy has a definite role in the treatment of low-grade lymphoma patients. Most of the time, chemotherapy nowadays is combined with the targeted agents, just like monoclonal antibodies or other biologic agents, which I will mention later on. Monoclonal antibody and radioimmunotherapy I will talk about in the next two slides. You heard a lot about stem cell transplantation, and just as in many of the other hematologic malignancies you heard about different diseases from Dr. Burns, this is a treatment option which is very important in patients with lymphoma. Both autologous transplant as well as allogeneic stem cell transplant has a role in lymphoma patients. When is the right time to do it? Who is the patient, an appropriate candidate for that, will be decided based on a lot of factors, including the factors that is important for the patient, as well as factors that we know from the tumor or the disease of the patient. And there's a set of new agents which I will briefly mention also in the next few slides. So let's talk about some principles of treatment using monoclonal antibody, for example. These are the new agents. You may have heard these names: ibrutinib or Imbruvica, idelalisib, Zydalig. Venetoclax is a more recently added drug, or Venclexta and obinutuzumab, and certain other monoclonal antibodies, which I'll mention during my next discussion on monoclonal antibodies. Okay, so this is the structure of rituximab, which, as you know, is the first monoclonal antibody that was approved in this country for treatment of any cancer, and it was for low-grade lymphoma, the first approval. and the approval was in 97, so it was about 20 years this drug is in the market. And the advent of this drug has changed the way we treat many cancers, not just lymphoma. So this is a molecule which is specifically against a protein that is present on the lymphoma cells, CD20. And this molecule attaches to the CD20 protein on the lymphoma cells and causes the cell to die by a unique way. That is, this is the cancer cell, and this is the protein on the surface, and the antibody attaches to that. And the antibody, this combination attracts certain cells called natural killer cells, which end up killing the tumor cell in a variety of ways. So it's basically recruiting body's own immune system to fight against the cancer cell. So it's a unique mechanism. Now, do we need to know, after the advent of rituximab, the first anti-CD20 antibody, there has been a variety of other antibodies which are thought to be even better than rituximab. One of the examples is the obinutuzumab, which I mentioned. This is actually also a monoclonal antibody against CD20 protein, has some advantages over rituximab. In fact, studies show that patients who did not respond well or has the lymphoma coming back after rituximab may benefit from the use of this drug. There is another monoclonal antibody in the market also called ofatumumab, which is also against CD20. So there's a variety of monoclonal antibodies, and CD20 is just one marker. There are many other markers on the surface of the B and the T cells which are also used for targeted treatment using monoclonal antibodies. Now, radioimmunotherapy is a FDA-approved treatment option for patients with low-grade lymphoma. The principle here is that you are using the same monoclonal antibody to carry radiation directly to the lymphoma cells. So this antibody can be used for carrying something, either radiation or drug or a toxin, directly to the lymphoma cells. So here, the antibody is attached to this radionuclide, and this is basically just like rituximab. You give it through the vein, it goes all over the body, and the antibody attaches to the cancer cell or lymphoma cell, and it also gives radiation locally to the cell. So it's a way of giving radiation to whole body without the usual side effects of whole body radiation. Again, this is an approved treatment. It is a very effective treatment, but it has to be a very selected group of patients who will be using it because radiation is involved, and you have to sort of prioritize and sequence the treatment because low-grade lymphoma is a chronic disease, and you don't want to do something in the front which can compromise your option for a future treatment. That's my last slide. Not to confuse you, another way of approaching low-grade lymphoma, which is probably the more recent approach, is to target some of the pathways which the cancer cell is depending on to grow. So if the cancer cell has to grow, it has to depend on many different pathways. And if you block those pathways specifically, you can kill the cancer cell without affecting any of the other functions, or other cells or other organs. So for example, one example of that drug is a pathway here. We call it BTK, or Bruton tyrosine kinase. And the drug that inhibits BTK pathway, ibrutinib, is one of the drugs now extensively used in B lymphoproliferative disorders. So similarly, there are many pathways which are being targeted, and some of the drugs that are targeting these are already in the market. So to summarize, as you saw, that in low-grade lymphoma, treatment options have changed significantly over the last few years. And not only treatment options, the diagnostic modalities we have also significantly changed. And how did these things happen? Primarily because of the research. And how did the research happen? Primarily because patients like who are here have participated in clinical trials. It's very important that we participate in clinical trials. It not only gives you opportunity to get these new drugs early, much before it comes to the market, but also helps in development of these new approaches of treatment. And I will end my talk here, and thank you very much for your attention.